part two. For those of you who were with us for part one, that was where we described blunt trauma that had a SVC injury. It was an interesting discussion, and this is part two, a different case, and hopefully an interesting discussion as well. And our presenter is Dr. James Choi, who's one of our senior residents here.
Hi, good morning, everyone from Westchester. So I'd like to thank the committee for allowing us to present our case today. Our topic is titled A Tale of Two Great Vessel Injuries. As Dr. Shnaydman had mentioned before, back in January, we had presented the first part, and now we're going to present the second case of our series. So the objectives for today was to discuss any relevant anatomy, of course, discuss any techniques for operative management, and to evaluate the injury mechanism and any associated injuries or risk factors for this particular patient. So to begin, this patient is a 32-year-old gentleman. He presents with a single gunshot wound to the right chest. On arrival, his airway was intact. He did have decreased right breath sounds on further evaluation. His systolic blood pressure was in the 100s, heart rate's in the 140s. GCS of 14, we took 1 point off given confused speech. And in terms of exposure, he did have one single aperture, which is outlined here right above the in the area of the clavicle, specifically in the right proximal clavicular head. At this point, we'd like to just break for discussion to see what everyone's thoughts are for the next step.
Thank you, Dr. Pereira.
Yeah, thank you for having me here. It's a great honor, and I always learn. Let's expose our ideas here. Well, I would start really considering a chest drain because the guy is unstable. In my opinion, the systolic blood pressure of 100 for a 32-year-old guy is low. I start draining the right side of the chest and see what happens after. So if you see, for example, you have a lot of blood from the output, perhaps directly to the thoracotomy, or instead, if you have no such a high depth, perhaps you can observe, go to the CAT scan or something like that. But I'd start draining the chest, and after it, perhaps an X-ray. Thanks.
Thank you, Doctor. Dr. Untrak?
Yeah, so I agree with that. So he needs a couple of IVs, blood setup, a chest tube on the right side. And the injury appears to be, based on the entrance wound, it's assuming that it's accurate, it's cephalad, so it's like between the first rib and the clavicle. So in other words, the subclavian vessels are at risk, and I want to know the systolic blood pressure 100. Which arm was that? Right, left? Is there any difference in the blood pressure on both sides? Pulses, but it appears to be that's where the injury is. So I'd put the chest tube in, see how much blood comes out, depending on the amount of bleeding on that side, with the tachycardia and blodd pressure of 100, he may need to go urgently to the operating room.
Thank you, Doctor. Dr. Colette, any comments?
Yes, I think this patient is unstable, but it's not too much unstable. I don't know what's the airway saturation, oxygen saturation of this patient. I think this patient is very important to find where is the blood for thinking about anything, because something's important. Sometimes in patients who have hemothorax, if patients has oxygen saturations, maybe good, you can put this patient in OR and put a chest tube in OR and then recover the blood and use the blood as such. Transfusion, transfusion. So this patient is possible to know if it's possible to reuse his blood in the chest. I think this patients, of course, is clear. If the patients don't have become unstable, you can put the chest tube, start with a transfusion, and recover the hemodynamical, and then you can have to make an image to say where is the bullet, because it's implying where to make the incision to treat the patient. If the patient's incision may be in the chest, on the upper, is one incision. If the chest is in the middle of the chest, other incision. If the bullet comes to the abdominal, it can make another incision. So I think it's very important to find where is the bullet. If you don't have, you can go with the patient may be unstable or suddenly stop cardiac arrest. You can make a thoracotomy. No chance of this. But I think it's important, very important, to make an image to see where is the bullet.
Thank you, Doctor. Dr. Kasim, any comments?
I think I would start with the clinical examination. Look at both the extremities to see if there is any loss of any pulses in the radial brachial area, and also get blood pressure on both arms so we can determine if any discrepancy from to the right to the left. And that'll give you some idea whether there is an injury to the subclavian vessel. And the rest of that would be exactly what Dr. Untrak said, which is put a chest tube, get an IV going on the left arm, and chest X-ray is important to see the trajectory as well as the site of the bullet. And sometimes, you know, these bullets, they bounce off and go to directions that you never thought of. And for that reason, I would also do a quick ultrasound of the pericardium to make sure that the bullet didn't bounce off into the pericardial area as well. So he is 32 years old, and even if he has lost some blood, he is compensated at this moment, but that is not going to stay that way for a long time. So you do need to get moving pretty quickly. Thank you.
Thank you, Doctor. Dr. Ochman, any comments?
Yes, quickly. I would do many things simultaneously, but while I'm doing the chest X-ray, I would obtain bilateral. I would check the bilateral systolic blood pressure. If it's a difference of more than 10% between the systolic blood pressure in the right arm and the left arm, I will suspect a subclavian artery injury. I will do the chest X-ray followed by any other X-ray that's needed. So depending on the location of the bullet, I will try to find if it went up or down or transverse, because that will determine what I will do next. I probably, depends on the chest X-ray, probably I will put the chest tube then. I don't think there's any rush to put the chest tube in this guy. He probably has a pneumothorax, might have a hemothorax. And I will delay the resuscitation on this patient, because most likely than not, this patient needs to go to the operating room, and delay resuscitation for torso injuries has a better outcome. So again, depends where the bullet is located. If it's what I suspect a transmediastinal gunshot wound, I will do one thing. If it went to the lower towards the liver, I will do something else. It depends where the bullets are located, where the bullet is located at this time. Thank you.
Thank you, Dr. Ochman. Dr. Burke, any comments?
Just what Dr. Untrak and Dr. Pereira said. I'd be hoping he had a tension pneumo on the right, maybe putting in a decompressing IV followed by a chest tube, angiocath followed by a chest tube.
Thank you, Dr. Nedeljkovic, any comments?
Hi, everyone. I agree with all the comments. I think this is an excellent situation where you should really stick to the ABC of trauma, really, looking at the airway, if the trachea can be injured. So make sure, if that's an issue with that, secure it and intubate. As the bullet, the other consultants mentioned that, can travel anywhere. Any diminished breath sounds on the right side would buy a chest tube, whether for pneumo or hemothorax. On C, I agree with Dr. Kasim to do pericardial fast just to see if he's been tamponade or not. I like Dr. Hohen's comment about not overshooting with
NTP activation for the torso injury. Checking the pulse to tell you in the upper extremity if it got the subclavian artery or not. Moving on D, if he would have any neurodeficits with a palpable pulse, maybe the bullet went and got the carotid. So that's something to keep in mind. And then see if he's moving lower extremities, then we'll tell you if he went and got the spine. And I think that's it for now. Get a chest X-ray and go to the operating room and decide, where you need to go next. Thanks.
Thank you, Doctor. Dr. Ivaturi, do you have any comment?
Yeah, I agree with everything that has been said. Excellent comments. I would just like to add a little bit different is that I would take resuscitation more acutely, so that I would put in multiple lines, upper half of the body, lower half of the body, and get a good blood gas immediately to tell me what the extent of shock is, because he's obviously in a compensated shock here. I would put in the right chest tube immediately, get a rapid chest X-ray, and then I would prepare to start a massive blood transfusion protocol, depending on his response to the chest tube and depending on what my arterial blood gas showed. That would be my point of further decision making, whether this patient needs to go to the operating room or can wait for other investigations. If he has to go to the operating room, I would not waste any more time. I would just take him to the operating room. Thank you.
Thank you, Doctor. Dr. Choi, we go back to you.
Not a problem. Next, we shot a chest X-ray, and this is actually what it shows. We have the paperclip pointing to the initial aperture, and the only aperture, and then a bullet which seems to be lodged in the area of the mediastinum. And here we have a pretty large tension hemothorax. So we began with resuscitation. We started MTP almost immediately. At the same time, we put in a femoral arterial line and a cordis. We also placed a right chest tube, which had a median return of 1.2 liters of dark output. We did a pericardial fast, which was negative. However, at this time, the patient's systolics did drop to the 70s. We also obtained an ABG, which showed pH of 7.04, CO2 of 49, PO2 of 40, a basis excess of negative 17.8.
Okay, Dr. Rochman, any comments?
Well, this patient is in shock, obviously, and this time needs to go to the operating room. The question is what type of incision for this patient. It's a difficult choice because of the location of the bullet. I will be suspecting, and based on the location of the bullet, I will be suspecting an SVC injury. So I would probably do this through a median sternotomy. Again, maybe getting a cross table lateral to get an idea how anterior or posterior the bullet is. But I think that this will be easier through a median sternotomy, although it cannot be argued that right thoracotomy will be a wrong incision. It's whatever a surgeon feels more comfortable in this case. I personally will go with the median sternotomy. Thank you.
Thank you, Doctor. Dr. Colette, your comments?
I agree with Dr. Rosman. I go to a median sternotomy because the patient may be injuries on the right subclavian area and have injuries of the probably superior vena cava. And if they have injuries on the pulmonar ileum, you can approach by the sternotomy, you can make increase or make a lateral thoracotomy associated. But I think I start with a sternotomy.
Thank you, Doctor. Dr. Kasim?
I think Dr. Hoffman is right. This is a very difficult case because you don't know what type of incision you should make because you don't have any imaging to back up for your choice. So my gut feeling tells me that I should do a median sternotomy, but my brain tells me that I should do a right thoracotomy because I believe I'll get more for my choice that I'm making by doing a right thoracotomy instead of median sternotomy. And but I think I am in a dilemma here. So I will stop there. I think I would like to do a right thoracotomy and go for broke. Thank you.
Thank you, Doctor. Dr. Antrak?
Yeah, so in this case, it's 1.2 liters of dark output. So I think that means it's venous or pulmonary arterial blood. And in that case, I would expect that the pulses are, no mention of the pulses, but the pulses are equal on both sides, relatively equal. So, and I think in that case, if it's not the pulmonary artery, then it's probably superior vena cava, but it's a tale of two great vessels. The last one was the superior vena cava already, so it wouldn't be that this time, but that's sort of artificial. But in any event, I think either one of those you can get good control of through a median sternotomy, the hilum of the right lung or the superior vena cava, and it'd be hard to. I can't imagine what else would cause that much bleeding on the right side. So I would agree. I would do I would give him some resuscitation on the way to the OR, and then also do a median sternotomy in this case.
Thank you, Doctor. Dr. Pereira?
Well, I have the same idea. First point is that patient is unstable. We should, whatever incision we are to do, we have to do it fast. We should not postpone it if you don't have the adequate material, or like the saw is not available, something that is more common in our part of the world. But I've been through this through an sternotomy, which is very good. And I had the opportunity to be with a partner through a posterolateral right thoracotomy. And both of them did very well. The only comment about the posterolateral right thoracotomy is that you kind of let the patient not in a total position for a posterior thoracotomy, but just partially. And you enter the pleural cavity in the third intercostal space. So you do the incision in the common fifth intercostal space. You go 1 or 2 space cranial to go into the pleural cavity. It was very well. It's time at the end of the meeting I can show some movies about this too. But considering all that, I'll try the median sternotomy, because of course, we have a venous injury very possible. We have the signs of a venous injury. We have dark blood, but we have to be prepared to examine all the vessels in the tract. So whatever we have, these vessels, they are very close. So even if we find a venous injury, you have to really look deeply in the artery and go beyond, perhaps in the posterior part of the mediastinum. You have to follow the track of the bullet to see where it goes. And if you see the bullet, I couldn't see it very well here, but it seems that it is in the mediastinum. Is it possible to be in the right hilum of the lung? Because if you see the project in the right hilum of the lung, you have to consider that the bullet just go through the heart to the pulmonary circulation. Thank you.
Thank you, Doctor. Dr. Ivaturi, do you have any comment?
Yes, I do. So these are patients in severe shock. Systolic blood pressure was 70, severely acidotic. So he's almost on the verge of a cardiac arrest. So as I said last time, I would look at these numbers before I make a move to the operating room. Now I changed my mind. I won't go to the operating room. I would do a right thoracotomy in the emergency department. And I'll tell you why. That gives me a lot of opportunities to pack the area that I think is controlled bleeding from, especially from the right apex. The subclavian vessels are injured, is bleeding from there. You could pack that apex with a tight gauze and then get some control of the bleeding. If it is a pulmonary hilum, if it is a lung that is bleeding, I can clamp the hilum and then take the patient to the operating room subsequently after resuscitating him and tamponing the hemorrhage somewhat. And also, I think that median sternotomy is a bad idea. If you have posterior injury to the major vessels or to the superior mediastinum. So the thoracotomy is the most versatile incision in this setup. So this patient in my center at Lincoln would have had a right thoracotomy in the emergency department. Thank you.
Thank you, Doctor. Dr. Nedelkovic.
I wasn't here for the first presentation, the first tale, but kind of looking at where the entrance wound is, the fact that the bullet kind of maintained its shape, probably didn't really hit anything else other than just kind of soft tissue, kind of maybe going behind the clavicle. We don't know what the pulses are, but probably maybe hit the subclavian vein. Dr. Vittori comments it's great. I think what I would do, it also depends on how far is your operating room from the trauma bay. So I think we have our OR like right next to the trauma bay. I would go to the OR with this patient. I would start with the median sternotomy, but also be prepared to bump it up and lift up and perform a posterolateral thoracotomy on the right side if I don't have good access to control the bleeding and the repair. Thank you.
Thank you, Doctor. Dr. Berg?
Yeah, I agree with Alex. I would go to the operating room and do a median sternotomy, and Dr. On Track and the others.
Thank you, Doctor. If anyone else has a comment, please let us know in the chat, and Dr. Choi, will go back to you.
Great. So thank you everyone for your comments. Before we continue with the patient's hospital course, I do want to take some time to talk about all the operative approaches that were mentioned. So we'll start off with the median sternotomy. So with the median sternotomy, it does give good exposure to the heart and the great vessels. But in regards to the posterior mediastinum, the exposure is not optimal. Also, it doesn't allow access to the descending thoracic aorta or the esophagus, and it provides limited exposure to the lung parenchyma. Also, keeping in mind that prior to the sternal divisions, the sternal attachments also need to be divided. Here we have a sternal saw going from the head down inferiorly. And then here we have a Klepsky knife with the hammer, which is also another way to open the sternum. Here we just see the options that can be extended with the median sternotomy. Keeping in mind that this patient's injury was on the right side, but nevertheless, we can extend the median sternotomy incision either superiorly through the sternocleidomastoid for cervical access for the carotids, or we can extend it laterally over the clavicles for possible subclavian vessel access as well. This patient is a prior patient, but again, this just shows the median sternotomy with extension over the clavicular bone. Again, this was on the left. The patient's injury was on the right. Pardon me. Next, anterior lateral thoracotomy. So this incision gives good exposure of the lung and the posterior heart. Worse exposure to the anterior mediastinum, but for patients who are hemodynamically compromised, it can be a good choice, given that you can also potentially extend this into a clamshell. For posterior lateral thoracotomy, again, good exposure of the posterior structures such as the descending aorta, the esophagus, the distal trachea, poor exposure of the anterior mediastinum. And in a patient who is otherwise unstable, it does require certain positioning. So this may not be, at least for this particular patient, may not be an optimal choice. We do have, again, more conservative approach to clavicular subclavian exposure. Again, it does give good exposure of the second portion of this subclavian artery and vein. However, this again is very, very limited. If you're concerned about other injuries to the chest, this may not be the incision to start with. I do just have a quote here from Dr. DeBakey, and essentially all it emphasizes is that really the most conservative incision is one that gives you entire exposure to the intrathoracic vessels. So we were able to bring this patient to the operating room. We performed a right anterior lateral thoracotomy, and we saw massive right hemothorax. We actually encountered active bleeding from the right subclavian vein. We were able to hold digital pressure against the chest wall, which tamponaded the bleeding somewhat. However, his blood pressure did drop to the 40s, and we were concerned for imminent cardiac arrest.
Dr. Ivaturi, do you have any comment?
I would also like to just mention the patient was taken to the operating room awake, and he was prepped and draped awake, so we were ready to go as soon as he was intubated.
Yeah, those are all good points. And like you said, it all depends on how far you are from the operating room. And if you have to go through 2 floors, elevators, etc., I suggest you do this in the emergency center. And you should be prepared to do these things in the emergency center. One important point you need to keep in mind with posterolateral thoracotomy and positioning the patient is a bad idea if you have a patient with significant lung injury and you allow all that blood to go into the other lung and then cause, in addition to the hypovolemia, the problem of hypoxia. So in general, please don't do a posterolateral thoracotomy for patients with acute trauma. The third point I would like to mention is right subclavian at the root of the neck or at the apex of the chest temporarily can be packed tightly, and that will control the bleeding. Or as you did, pressing against the rib wall can actually control the bleeding also. That allows you time to resuscitate the patient, open the pericardium if you have to, do an internal cardiac massage, and do other resuscitative maneuvers. And then it will allow you some time to decide what you're going to do. Are you going to expose the right subclavian, maybe putting in a balloon, cause a proximal tamponade, control the bleeding, expose the injury, and repair it? Or are you going to ligate it? All of these allow options. And then all the steps that I've encountered or enumerated will allow you the time to go through this in a rather less haphazard fashion. Thank you.
Thank you, Doctor. Dr. Colette, any comments?
Yes, in this situation, it's very, very difficult to treat because we start with a right thoracotomy. For subclavian assessment, it's very difficult. Sometimes you can see the entrance wound. You can put through the entrance wound a Foley catheter, insufflated Foley catheter, and then can push it, try to push it, and then you can control sometimes the hemorrhage in the situation and have get time to make make the other maneuvers. In these situations, I can go to a bilateral thoracotomy in this moment because the patient is going to cardiac arrest and open the left chest, open the pericardium, and start massage. When we make a thoracotomy by a transverse sternotomy, you can have access for the proximal portion of the subclavian arteriole, the brachiocephalic trunk. Then you can make control, put a clamp, across clamping. Sometimes in these situations, you have injuries on not only the arteria, but you have used the vein, and vein is not very easy to control in this situation. So you can see what is seen during the section on this portion, and then you can go to direct approach by the cervicotomy in this moment. Okay.
Thank you, Doctor. Dr. Burke, any comment?
I would extend it into a clamshell and try and get better access.
Okay, thank you. Dr. Ochman, Boston.
Well, I have to say that when Dr. Ivaturi suggested doing a right thoracotomy, the way he presented that made a lot of sense. And he's a master of surgery, and I kind of like, I think this is very, very important. It's kind of like depends on the situation you are. And I agree with all his points, and anterolateral thoracotomy is the way to go, not posterolateral thoracotomy. I've been in that situation where the patient bled, even when the patient is laying flat, bled into the other lung, although this patient didn't have any hemoptysis, anything that suggested the lung injury. So I think that Dr. Ivaturi's points are really very good ones, all of them. I agree with Dr. Burke and others that this has to be extended to a clamshell. If you have an anterolateral thoracotomy, because in my personal experience, I hardly ever solve anything through an anterolateral thoracotomy. I always ended up doing a clamshell because you go for an incision that gives you very limited exposure to an incision that gives you usually excellent exposure of the whole chest. Having said all of this, I think that Dr. Colette was kind of nailed it on the head when he said that for this exposure through a median sternotomy, the exposure of the carotid and the subclavian vessels, either with an extension to the neck or a supraclavicular extension, is much easier, give you much better exposure. So, and at the end, in the cases like this, and not all being if you're lucky or not, because again, both options are good options, a median sternotomy and a anterolateral thoracotomy. It depends on the circumstances. There were injuries that you would not be able to address one way or the other. So it's kind of like the experience of the surgeon at that particular time, thinking what it will work better for him or her. And I think that's, and it's not a gut feeling, it's really, it has been studied. This is a pattern recognition, which is done by the right side of the brain. And it's based on experience, having seen hundreds of similar cases, and the decision that we tend to think, oh, I had this feeling, is not that, is the right side of the brain recognizing something that, because the right side of the brain is non-verbal, it's very difficult to put in words. So that's all I have to say on this case. I agree with Dr. Collet. This is a very good incision to access the proximal subclavian carotid innominate artery, SVC, and this will be much easier that way. Thank you.
Thank you, Dr. Antrak.
Yeah, so I agree. That was a very good point by Dr. Ivaturi about positioning for a thoracotomy, not putting the patient up on the with the bad side up. But anyway, regarding this case, I'm a little perplexed about the comments about the clamshell, only because the bleeding is coming from the right subclavian vein, and the patient. Had you done the median sternotomy, then you would have control proximally or distally in the vein, and then you could extend the incision to the right axilla the way you showed in the diagrams, and gotten control of the proximal side of the vein and gotten good control of the bleeding. But in this case, with the compression from inside the chest, you could still make the incision along the inferior edge of the clavicle and then the supraclavicular portion, and try to get control that way. For the clamshell, I'm not seeing how that would help you get control of where the patient is bleeding on the from the right subclavian. But and I would assume once you were able to decrease the bleeding with digital pressure, that he'd respond to resuscitation at that point to prevent the imminent cardiac arrest.
Thank you, Doctor. Dr. Parreira?
Well discussed. I think what's the most important thing at this point is to compress the vessel against the wall and stop the bleeding. If you achieve it, your first goal in the operation is done. You got a temporary hemostasis and you have to resuscitate the patient. That is my idea. Compress it, stop the bleeding by compression. I understood it was successful. Then after that, you go to volume resuscitation. Eventually, if you had to, well, if the patient goes to a cardiac arrest, you'll be obligated to cross clamp the aorta. So you have to go to the other side and do it through the left side, or you got a reboa, you go through. But I think reboa in this situation is very complicated. We don't have this experience in Brazil yet. So we probably, if the patient goes to a cardiac arrest, we'd probably go through we'll go through the clamshell and cross clamp the aorta from the left side. But I agree with Dr. I don't know who said it, but we can do a classical incision on the clavicle, above and under the clavicle to expose the vein. If we are talking about subclavian veins, it's better through this way than the clamshell. The clamshell we're going to go, it's not, I don't think it'd be a good exposure. You have to add another incision. So first point is to compress the vein, resuscitate the patient, and then perhaps call for another guy to think what to do, a vascular surgeon to share some experience. But honestly, I would decide depending on my anatomic idea where I can get it more securely. Thanks.
Thank you, Doctor. Dr. Kasim, your comments, please.
When you observe the master surgeons like Dr. Venturi and others perform surgery, they bring in their toolbox into the operating room, while young surgeons who are just starting, they merely rely on their scalpel. And in a case like this, Dr. Venturi tells us that he will do emergency anterolateral thoracotomy and pack it. That is his tool, packing it. And others in places like South Africa and other places that I have seen, they use balloons. And Dr. Collet is a master surgeon in using the balloon. And I think you have to be cognizant of the fact there are tools available for you to stop the bleed. And what we are talking about in this case is the patient is bleeding from the subclavian vein and you need to stop the bleed somehow, whether you pack it or use a balloon or you cross clamp. And when you have an open chest, when access is not possible, you need to use whatever is available in the toolbox to stop the bleed. Otherwise, you will end up here like imminent cardiac arrest. I think doing a clamshell incision here is not going to really help you much. What you are looking for is how can you possibly stop the bleed and get the reconstruction done or ligation done so that the patient can be salvaged. So I think in my hands, I think I would probably either do a balloon or a packing and catch up with the patient and see if I can get the hemostasis achieved. Even if I can take the patient with packing or a balloon or something like that, so I can come back later on and to deal with it. I think Dr. Supra once had a case he presented that he had an uncontrollable bleed from the right chest, and he packed it and took the patient to the intensive care and brought him back the next day. And I thought that was a fabulous save. And that's what I'm thinking in a case like this. I don't want to be wasting time doing this and that. which is not going to be fruitful for the patient. Thank you.
Thank you, Doctor. Dr. Nedeljkovic, any comments?
So I agree with all the comments. The sternotomy would be a better approach to access and control the bleeding. Now you're in this situation. So if the other thing would be it's a big vein, there's a possibility that a big air embolism is causing all this now if you control the bleeding, and that can be a problem that cannot be fixed without either sticking something in the major vessel to aspirate all the air versus if it's really arresting in front of you now, you may have to do the clamshell as it was presented by other doctors. Rebois is not indicated for major bleeding in the chest, but I could see why somebody might be tempted to prevent imminent arrest by putting the balloon up as you are holding pressure against the vein to prevent the heart arrest. The other option would be to just, through the whole stick of Foley or 2 Foley balloons and inflate them and add maybe a sponge stick through the incision to hold pressure and see if that leads to improvement of blood pressure. I'm curious to see what you ended up doing. Thank you.
Thank you, Doctor. I see Dr. Ochman and Dr. Ivaturi has a comment. Dr. Ochman?
Yeah, I would like to clarify the clamshell. I agree that it's not the ideal incision base for something like this, but I guess I am not such a good surgeon, but I always have a very hard time accessing things in the chest through a pure anterolateral thoracotomy. Give you very, very poor access. You are already there in a patient who is in imminent cardiac arrest. You don't have time here to start thinking, oh, we are going to try to do this or that. There is another option, which I personally don't do. I have seen surgeons doing this. I think it's a very bad option for many reasons, and it's do a trapdoor. So you can do an sternotomy from the area that you meet, an sternotomy from that area, and you can extend the incision on top of the clavicle. That will give you a very good exposure. However, it's very morbid. The reason to expand the incision is that you know that it's bleeding from the left subclavian vein, the right subclavian vein, but you don't know what else is injured. It's bleeding from that area. So if you need to get proximal control in the innominate artery and the left subclavian, it's particularly with the location of the bullet, a supraclavicular incision will not be enough. So I am there already. I have a right thoracotomy done. I will extend to the left chest because it's the fastest thing that I can do in a patient with imminent cardiac arrest. It's not the best incision, but it's the best for that particular circumstance. That's what I was trying to say. Thank you.
Thank you, Doctor. Dr. Ivaturi, your comments?
Yeah, first let me thank all the speakers for their nice comments they made about me. I'm just thinking about some of the cases we have had. And Dr. Wong said he put digital pressure against the chest wall. I don't know how they did that. But one thing that occurred to me is that when you have the right chest open, and if you think the right subclavian is bleeding, you could just have an assistant put his finger through the bullet hole, press it against the clavicle anteriorly. And if that staunches the bleeding and you reduce it somewhat, then you know that your major problem is the right subclavian. And that will give you a few moments to then plan your next incision. If it is just the right subclavian, you can easily do a transverse incision along the clavicle, resect the clavicle with the assistant's hand right there pressing on the subclavian. And that will give you excellent exposure of the entire subclavian, artery, vein, etc. And allows you to go proximally if you have to. And if that does not give you the exposure that you need, then you can always add the median sternotomy or even the across the sternum to the other side as a clamshell. So to get a few moments, this kind of a simple maneuvers can really provide you a big advantage. Thank you.
Thank you, doctor. We go back to you, Dr. Choi.
So thank you for, again, all the comments. And so I just wanted to clarify, so even with digital pressure, the patient's systolics did continue to drop to the 40s. Our main concern at the time was for imminent cardiac arrest and the potential of doing a cardiac massage. So what we did for this patient was we actually extended the right thoracotomy to a clamshell thoracotomy. One of the two things that I wanted to point out in this picture, and this was an intra-op photo, is one is the Finichetto retractors, that the handles are pointed inferiorly. This is to prevent, again, the handles abutting the axilla, and it allows us good exposure to the chest and the great vessels. The other thing to keep in mind with a clamshell thoracotomy that I wanted to mention is ligation of the bilateral internal mammary arteries and veins, which run parallel alongside the sternum. So for this particular patient, after the clamshell thoracotomy, we did have better digital pressure on the subclavian vein. Bleeding was controlled, and his systolic blood pressure did improve with continued resuscitation. We were able to get distal control at the junction of the SCV and superior vena cava junction. And then the right subclavian vein was ligated using a 3-O-proline, which was tied near the junction. We also had saw hemorrhage from the right upper lobe. Upon further exploration, there was a tract from the bullet that was causing the hemorrhage. So we performed a tractotomy and a wedge resection at the time as well. To further illustrate the ligation, here we see the right subclavian vein, and the arrow is pointing to the first tie that we did. There is a second tie closer to the junction, the origin of the right subclavian vein. And the reason why we tied it there was to prevent any potential thrombus that could form from the blind end. So here we have a better image intra-op. So we see the left innominate vein, we see the SVC, and then we have two ties, one at the origin of the right subclavian vein at the junction of the SVC, and then another more distal along the proximal edge of the the proximal border of the right subclavian vein. On further exploration, we also found that the bullet actually did strike the area of the T6 vertebrae. There was hemorrhage from this area, so we had to ligate the intercostal and lumbar vessels. After 18 units of PRBC, 20 units of FFP, 3 platelets, and then 10 of cryo, miraculously, the patient was stable at that point. We placed 2 chest tubes on the right, 1 chest tube on the left, and then 1 in the pericardium. Next, post-operatively, the chest was closed, and post-operatively, the patient was stable enough to be brought to the CT scanner to further evaluate the spinal injury. And there we saw comminuted fractures of the T5 and T6 vertebrae with displacement of the right T6 pedicle into the spinal canal. So for this patient, at least post-op day 4, we actually involved our neurosurgery colleagues. They performed a decompressive laminectomy of T4, T7 with excision of the bone fragments. The patient did have a prolonged intubation in the ICU, and he did have ventilator-associated pneumonia requiring a tracheostomy. His right arm, there was some edema to the area, but that was well managed with compression. He's actually currently recovering in the TICU, and he's doing quite well. He's actually decannulated. We thought at first that he might be completely paraplegic, but he's actually able to move. There is some movement to his bilateral feet, and we are planning to transfer him to rehab hopefully soon. I wanted to take.
I just want to add, since Dr. Choi hasn't seen the patient the last couple of days, he was transferred out of the hospital to rehab. He's decannulated from the trach. He's eating a regular diet. His arms are fully functional. He's starting to move his feet. So we're hopeful that he continues to improve neurologically.
Perfect. The last couple of slides I just wanted to touch upon just the literature surrounding these types of injuries. So here we have an article from Dr. DeBakey and his group. This is back in the 1980s, management of subclavian vascular injuries. So the point for this paper is that even with a 24-year experience at Ben Taub Hospital in Houston, there was within this 24-year span 93 patients, of which there were 61 subclavian artery and 50 subclavian vein injuries. So even over the course of 24 years, these types of injuries are very, very rare. Of these 93 patients, 8 had pulselessness on presentation. 6 anterior lateral thoracotomies were performed, 2 clamshells. 7 at the time posterior lateral approaches were performed, and then 31 trapdoor or book thoracotomies were performed as well. Of the patients, 28% underwent vein ligation. And here is just a picture of the trapdoor incision that was mentioned during the comments earlier. Next is a Western Trauma Association review. So this is just a multi-center review, 11 retrospective studies over a 10-year course, looking at 223 patients, of which 128 had subclavian artery injuries and 119 had axillary artery injuries. And the point to get across here is that, again, for subclavian artery injuries, the mortality is pretty high, at least a third of the patients. One of the things to mention is that if the patients are stable, that a pre-op CT can be considered for these patients. And for these 223, at least 50% of them who were stable did have preoperative CT scans performed of their chest. Here we just have a quick algorithm. Again, the point to highlight is that if a patient is hemodynamically stable, one can consider a CT chest CT angiogram. However, if the patient is hemodynamically unstable, the goal is to resuscitate and have distal and proximal control of whichever artery or vessel is bleeding, and of course, ideally in the operating room. Lastly, we just have a paper from Dr. Feliciano and his group from Jacksonville, Florida. This looks at the outcome of ligations of major veins for traumatic injuries. This is a review of 5,000 articles, of which 93 were selected. Dr. Dimitriadis' paper, interestingly enough, noted that for subclavian vessel injuries, the mortality was actually higher when compared to subclavian artery injuries, which is 20.5%. So overall, 45% combined for both injuries. And Dr. Robs and his group found that within his 2-year period with 9 subclavian vein ligations, only 2 developed upper extremity edema, of which our patient also developed, but again, usually resolves with adequate compression and elevation within 5 to 7 days. Again, thank you everyone for your attention. That concludes this portion for our grand rounds.
Thank you, Dr. Choi. We'll go quickly with final comments. Dr. Burke, any final comment?
That was an amazing case. That was a tour de force. It's amazing you got that guy at the table alive. Awesome job.
Thank you. Dr. Pereira, any comments?
Again, thank you very much for presenting the case. I learned so much. I think, well, great case. The guy is alive because of your skills. So thank you for sharing. Let me show you a 1-minute image here, Valeria. Can I share my screen? Valeria, okay.
Yes, please.
Okay, let me show the case I was showing. I presented this case in the American College of Surgeons meeting. Dr. Ivaturi was in the table. He was he was there as a panelist, so he commented this video. I'm not sure he remembers this one. It is not a total left-right thoracotomy. It's just part of it. You put like some kind of stuff here to put the to keep the patient in this position. And you see, let me put here, you go in the 50 space here, but when you enter, you go just 2 spaces cranial. So you are able to expose, let me show here, here, here. See these positions, just let me show you here. You are. Here is the heart. This is the phrenic nerve. This is the superior vena cava injury, and the right subclavian is right here. So it's very good exposition. I think it's a tool for you to decide to use. Thank you.
Thank you, Dr. Pereira. Dr. Antrak, any final comments?
Yeah, so yeah, magnificent case. And then also the excellent intraoperative photographs. And that answered my question about the exposure you would get from a clamshell thoracotomy. You, in fact, had excellent exposure of the entire upper anterior mediastinum. So you can see the superior vena cava, and also the innominate vein and the distal right subclavian vein, and get control of the entire venous injury. So that actually proved to be perfect in this situation. So I learned a lot here in this case.
Thank you, Doctor. Dr. Colette, the comments?
Yes, I have congratulations for the case. It's a very interesting case. It's very difficult to treat, and it's very important to share these options to all people to know when we have a case like this, how to do. Thank you very much for the presentation.
Thank you, Dr. Colette. Dr. Kasim, your comment? You're muted, Dr. Kasim.
Again, it shows when you have competent surgeons like Dr. Shnaydman here, he uses all his tools to be able to stop the bleed and get the problem solved one way or the other. And then also, he teaches us to look for other injuries that you may have missed. And I think there is a lot of pearls here to take home to. And thank you for sharing this case. I learned a lot from you today.
Thank you, Dr. Kasim. Dr. Rahman, your final comments?
Besides congratulating the presenters, I would like to tell them that I am very envious because this case left me salivating. This was a terrific case. Congratulations to you, how you handled this. I have to say that as always, this conference, I learned a lot, and this is not an exaggeration, how to solve the same problem in multiple ways, add to our armamentarium when we are facing with these very difficult situations. Two things for the young surgeons here that might find useful. One is that for the left subclavian, surprisingly, that's where you have that incision you were showing, the trapdoor on the left side. For the left subclavian, the second intercostal space give you a very good way to quickly get proximal control, which is kind of a very counterintuitive to think that way, because until I saw it, I never thought that that incision was going to be useful, but surprisingly, it is very useful. And finally, another thing I will show my age. When I was young and we were residents, whatever, we were doing thoracotomies in the ED left and right. And we were kind of competing among the chief residents who could do it faster. And we were all trying to be within 30 seconds to cross-clamp the aorta. And one trick that I learned there, who served me well and hopefully will serve somebody else in the future, is not to use the technique that is being described in the book and putting a clamp and cut on top, because you don't have time, or using a scissors. Is two cuts. One, I identify a rib, cut with the knife all the way to the rib in one cut, and after that, just one cut above the rib, and I am inside the chest. And that's really very, very fast. You don't have to worry about bleeding. You deal with the bleeding later. But that is a very quick way to get inside the chest and cross-clamp the aorta or do something else like in a case like this. That's all I have. Thank you very much. And again, I'm very envious. I really would love to have a case like this here. Thank you very much for presenting it.
Thank you, Dr. Rahman. Dr. Ivaturi, your final comments. Thank you for your patience.
Thank you very much. It's a great case. Dr. Choi, it's excellent presentation of the case. Very well managed step by step all the way through, and a great review of the literature. So thank you. I appreciate that very much. I learned a lot from the other discussants.
Dr. Ivaturi, you're muted.
Sorry.
Okay.
I learned a lot from the other discussants too, that you can arrive at the same favorable end with multiple solutions. All you have to do is take it step by step, do what you think is best at the moment, and not get sidetracked into difficult decisions. So I learned a lot. Great presentation by Dr. Choi, great review of the literature. I appreciate the opportunity to share our little bit of experience with the others and learn from them. So thank you very much.
Thank you, Dr. Ivaturi. Thank you all the panelists for your comments. Thank you, everyone.
Thank you. Thank you all.
Thank you, everybody.
See you
And thank
later.
you, Valeria and Dr. Martos, for excellent conference that every week we learn from.
Thank you. Thank you.